So I wanted to spend a few moments talking about these different muscarinic receptors. There's five, and the ones with the gold star are really kind of the ones that we're going to focus on for today's lecture. So M1, M4, and M5 are more or less found in the CNS, and so we're going to kind of table those receptors for the brain behavior and cognition blocks. So we'll come back to part of this lecture series in the next block. I want to focus on really M2 for the sake of review, and then M3 for the sake of kind of some of these other organ functions that we need to discuss. And then, of course, because of the way this topic fits into this case, we're going to focus on the nicotinic sub-M receptor, the neuromuscular junction receptor. And so these two muscarinic receptors basically are G protein coupled receptors. Within the myocardium, we're looking at an opening of the potassium channel. And then within some of these glands and smooth muscles, we're looking at how upon agonist binding, we see the formation of IP3 and DAG, which basically translates to an increase in the amount of intracellular calcium. Okay, and then of course with the nicotinic receptor, we're looking at an opening of a sodium potassium type channel and the production of depolarization. So let's talk about the M2 receptors. Part of this is review. So the M2 receptors are profoundly expressed on the myocardium, and so we're going to kind of look and compare and contrast what agonist stimulation on an M2 receptor does in relation to beta 1. And so this is your myocardial cell. This is review. Here you've got norepinephrine or epinephrine binding to the beta 1 receptor, positively stimulating adenyl cyclase. And you see this downstream effect, which essentially produces more calcium inside the myocardium, which produces or facilitates contraction. And so you can think of norepinephrine or epinephrine as applying gas to a moving car, resulting in an increase in heart rate. Okay. Now, when you look at vagal effects, and so we're looking at the ninth cranial nerve and its ability to spit out acetylcholine. This is parasympathetic or cholinergic stimulation. They're one and the same. You can see acetylcholine has an inhibitory effect. Okay, an inhibitory effect on adenyl cyclase, and so less calcium becomes mobilized within the myocardium, resulting in less contraction. Okay, so less contraction translates to a reduction in heart rate. And so the analogy would be applying brakes to a moving car, so the car being the heart or the cell. And so here when you see acetylcholine hitting these muscarinic receptors, which are G protein coupled receptors as well, you see an inhibitory effect on the GI, an inhibitory effect on adenyl cyclase via GI signaling, and you see a reduction in heart rate. And this nicely summarizes the compare and contrast what sympathetic stimulation does on heart rate compared to parasympathetic stimulation. And so yeah, there are M3 receptors on the heart, but the profound effect is really looking at M2 activity. Just like there are some beta 2 receptors on the heart, but the profound effect is really governed by beta 1 activity. Okay, and so it's kind of the difference between maybe physiology and pharmacology is that physiology and even histology would report that there are these receptors that are found within a specific anatomic compartment, but from a pharmacological perspective, those receptors have a very nominal, if any, effect, just because they're few in number. Okay, but they're physically there. There's just not a real large response. And so when you think about the heart, you think about beta 1 binding to norepinephrine, and now you can think about M2 binding to acetylcholine. Okay, and so when that acetylcholine hits that M2 receptor, these are some of the organ kind of specific effects, and so this basically summarizes what I just said. You see an increase in potassium current, you kind of decrease the inward calcium movement in some of these myocytes, and then you see a reduction in the hyperpolarization state. And so all that translates to is a slowing of the pacemaker rate or the pacemaker status, and you see a reduction in heart rate. Okay, so that was the M2 receptors. How about M3 receptors? Well, M3 receptors we had kind of already talked about briefly. Basically, whenever you have um, an M3 effect, we're looking at kind of smooth muscle. So some of your non-specific muscarinic agonists, including acetylcholine, would produce bronchoconstriction, which is shown here, as well as an increase in the secretion of some of those mucosal cells. And so we had already talked about a specific muscarinic antagonist that maybe you have forgotten, hopefully you haven't forgotten, but we talked about it in asthma, and this was ipratropium bromide. And so this is an M3 antagonist, or an M3 blocker, and it's responsible for producing bronchodilation. Okay, and so the clinical correlation here is going to be asthma when muscarinic antagonists are supplied as inhalation or aerosol drugs. Okay, a lot of what we're going to talk about today is systemic effects, and so this is just kind of the exception. Other M3 effects include salivation, which is shown here, and there is a slight M1 effect, but the primary mechanisms by which saliva is produced is really kind of governed by M3 receptors within the smooth muscle. And so when these M3 receptors are stimulated, you can see that there's a contraction of the smooth muscle gland, and you can also see the secretion of watery saliva. And so from a clinical standpoint, where do we see problems with this? Well, patients that have, xerostoma or, persistent dry mouth. And so we can give drugs to kind of alleviate that so that they have kind of a more saliva production. And several drugs can cause dry mouth, many of them chemotherapeutic, but some other ones too. I don't think we've talked about any yet. Other M3 specific effects include lacrimation, or the ability to cry, and so or produce tears. And so, in terms of clinical correlation, there are some patients that, for a variety of reasons, have dry eye. You can supply liquid tears, which we'll talk about in the eye unit. Several antibiotics can assist with that, assuming that there's some type of eye infection. And then, of course, the brand name drug is Restasis, but the generic is cyclosporine, and this is one of those anti-immune modulators that you can apply topically. And so, all of these are related to this notion of having dry eye. But in terms of tear production, that's really governed by M3 activity as well. And then also the ability of the iris to change size and contract is also governed by M3, and we'll show you what that looks like in a little bit. So this is just kind of a nice overview of M2 and M2 and M3 effects, and I think now we'll kind of get into the drugs.